It's my pleasure to be here today to present to you and to be back at UCLA. Even though it's nighttime here, I'm very excited to be able to present to you about the South African response. So thank you for inviting me to talk today, and thank you for all attending. So like Annie said, I am an assistant professor of epidemiology at UCLA, and I'm also an alumni of the program. I'm also based here at the University of Cape Town, where I'm an honorary senior lecturer in the beautiful city of Cape Town that you see here. And I will be presenting about the South African response to COVID-19. So just as an outline, I'm going to give you a background on South Africa. I'm not assuming that you know everything there is to know about South Africa, so I'll give a bit of a background. I'll talk about the government response to COVID-19 pandemic, the epidemiology of COVID-19 in South Africa, before and after the government response. I'm going to present a couple of slides of a colleague of mine did some really interesting analysis that's about to be published about the impact of TB and HIV on COVID-19 mortality in the Western Cape, where I am based. I'll talk a little bit about how my life has been and my research has gone on during COVID lockdown, and then I'm happy to take some questions at the end. So this is beautiful Cape Town. You can see we have the beaches, the city, and Table Mountain. And we had some really interesting campaigns: mask up in public, stay home if you can, all over the city at this time. And the COVID lockdown in effect was posted all over the streets. So the background of South Africa, the population's about 58 million people, unemployment's about 30%. We have the largest HIV epidemic in the world, with 7.5 million people living with HIV, which is a 19% prevalence of people from 15 to 49, and 200,000 new HIV infections in the last year. You can see that South Africa is at the tip of the African continent. And we also have one of the highest TB burdens of tuberculosis in the world, with 322 active cases of TB in 2017. 60% of those are also infected with HIV. And non-communicable diseases are also on the rise, including diabetes, which are one of the top causes of deaths. And 39% of deaths are attributed to NCDs, or non-communicable diseases. We are also deemed by Time Magazine and others as the world's most unequal country. So you can see in this picture here on the left-hand side of your screen, Johannesburg in South Africa, with the nice homes and the pools surrounded by a township of largely shacks. And that's the reality of the situation. So when SARS-CoV-2 came to South Africa, there was a lot of fear that it was going to devastate the country. And you can see here on the right, the number of deaths in 2016 for broad causes in Western Cape by age of death. And this is just to demonstrate that a lot of the deaths, especially in men, are intentional injuries. So violence caused and injury caused in men. And it's mostly TB and HIV in women in that middle age group there. And so what happened in South Africa when COVID came to our shores? So in March 15th, we had the first case. March 5th, we had the first case of COVID diagnosed in Durban from a traveler who had traveled to Italy. And President Ramaphosa addressed the nation 10 days later, declaring a national state of disaster. He announced the government is taking urgent and drastic measures to manage the disease, protect the people of our country, reduce the impact of the virus on our society and our economy. And we watched this presentation, and everyone watched it and was really, really scared, but we were drawn to action. We really couldn't do anything else. And so 23rd of March, he announced a national lockdown. And the national lockdown was very strict. It was initially for 3 weeks, and it outlined a more stringent interventions, a comprehensive plan to limit the transmission of COVID and to mitigate both its economic and social impact. So you can see here just a timeline that was published by some colleagues illustrating the trade-offs in South Africa's response to COVID-19. The 5th of March, the first case was in KwaZulu-Natal province. You can see the first case is here. The president announces the measures on the 15th. 21 days between then, the first case diagnosed from travelers from Europe, the national lockdown. So the national lockdown went to a hard lockdown on the 26th of March. Ports of entry were closed on the 16th and 17th of March. And then there were 65 days of hard lockdown with police-controlled movement on the streets and limited essential services until the 1st of June, when the government started to relax the conditions to alert level 4 and alert level 3. In addition to this lockdown, there was a big problem with food support. People were no longer working. A lot of people in South Africa are living day by day or week by week in terms of their income. And so the food support was a big issue, and food was provided by governments, NGOs, and CANs. And I was part of a CAN, which is a community action network of volunteers that gave food support to our local communities. So the economic response had 3 phases. In March, it was really to mitigate the worst effects of the pandemic on businesses, communities, individuals, include tax reliefs, release of disaster relief funds, emergency procurements, especially PPEs, and wage supports. In April, the government aimed to stabilize the economy, addressing the decline in supply and demand and protecting jobs. And this included a social and economic support package of $500 billion, which is equivalent to about $327 million. And then the third phase was recovery, which is the current phase. We're aimed at driving the recovery of the economy as the country emerges from the pandemic. We know we haven't quite emerged, and I'll show you that in the epi data in a little bit. But they're still recovering the economic situation through tax relief, disaster relief funds, et cetera. The government's goal was to steadily increase economic activity while putting measures in place to reduce the transmission of the virus and provide adequate care for those who became infected and needed treatment. So we have a risk-adjusted strategy. That's a national strategy. In March 26th, we started with the alert level 5, drastic measures to contain. So we were all at home. No one could really move around except for if you were an essential worker. Alert level 4 came down a month later to extreme precautions to limit transmission and outbreaks. It wasn't a month, actually, it was 6 weeks later, while allowing some activity to resume. Alert level 3, restrictions on many activities, including workplaces and socially, to address the high risk of transmission. So you can only get together with fewer than 20 people in your house. Alert level 2, physical distancing and restrictions on leisure, but schools largely went back to academic teaching, in-person teaching between level 3 and level 2. Alert level 1 is where we are since September 21st. So about 2 months now. Most normal activity has resumed with precautions, and I'll talk about those precautions. And the population is always prepared. So whenever we hear the president speak, we're worried that we're going to go back up to level 2 or level 3. And I'm confident that will happen probably in the next few months as we go into the second stage. So prohibition, I wanted to show this video quickly just to show about the prohibition, because we were one of the strongest countries in the world to ban all exercise. We couldn't walk outside. Even walking the dogs or walking on the beach was illegal and punished and enforced. Alcohol and cigarettes were banned until October for 5 months. When they opened from 9 to 5, Monday through Friday. Actually, it was Monday to Thursday. Friday, you couldn't buy any alcohol or cigarettes. And they recently reopened cigarettes and alcohol a couple weeks ago. So this is from the BBC. I don't know if you can hear this.
No, there's no sound coming through, Dvora.
Okay. So you can see it was a pretty devastating time with the police chasing people around. The BBC footage, and I can share it with you later, pretty much shows that people were making illegal alcohol, bootlegging alcohol and cigarette sales, which increased a lot of the violence and crime in the community. So travel to South Africa was closed in March, and since then in October, South Africa borders were open for business and leisure for international travels. In November, just last week, we've opened up for international travel. But travelers are expected to abide by the regulations, which include mandatory wearing of masks at all times. So this is even under level 1, practicing social distancing in public spaces, regular washing and sanitizing of hands, and presenting a negative COVID test not older than 72 hours from the time of departure. Upon entries, travelers will be screened for symptoms or for contact who they've had. And you can see here the risk categorization of travelers. Anyone from the United States would obviously be high risk. and the United States couldn't travel until recently. And then medium risk is from countries with relatively equal numbers of infections and death toll to South Africa, and low risk are countries with lesser number of infections of COVID and death toll less than South Africa. So when we have a comparison here, we're going to talk about first the stringency of the government response and the number of cases per million people. So you can see this is all confirmed cases per million in Africa's 10 largest economies. And this is through June. And you can see that South Africa far eclipsed all of the other countries. The country below here is Morocco. So we had more than 400 cases per million people in June and July. And we had one of the most stringent government responses also in April of this year. You can see that the stringency rating from an Oxford government response tracker was one of the most stringent, along with Angola and DRC here. So we had one of the most strict responses. And the rapid response really had an impact, a direct impact on mobility. So you can see here in every province in the country that after the lockdown in March, that the percent change in retail and recreation went down significantly throughout the country. So when we talk about the impact of lockdown, the swift and forced lockdown led to reductions in mobility, like I just demonstrated, among the population and reductions in cases and mortality of COVID. People were willing to act, and they were, if they weren't, they would be followed by police. I got pulled over many times by police when I was going to work as an essential service worker, and I had to pull out my card saying where I was going and the letter where I was going to ask them to let me through. And they were really willing and able to act in the provinces hardest hit, including where I am in the Western Cape, which is one of the provinces hardest hit by the pandemic in its early stages. The compliance with lockdown was really challenging in rural areas and impoverished urban areas, deepening the divides in the country, like I demonstrated in the first slide, as the most unequal country in the world. So the government continues to weigh how best to offset the costs faced by already marginalized populations. For example, my colleagues' research has shown that the impact of lockdown has seen on increasing gender-based violence, violence against children, child neglect, hunger, and cases of mortality of other diseases because of limited access to care. So here again, we see the inequality, the top 20 versus the bottom 20, and this was published in South Africa. So the top 20 say, I can't go out to walk the dog, I'm experiencing cabin fever, I'm queuing for groceries, I have about 2 people in my household, and my income is about $1,500 per person per month, $1,500, let's say. And they have to stay at home. And the bottom 20 can't find work, experiencing actual cabin fever, queuing for grants, more than 5 people in the household, and about $50 per person in a monthly income. So you can see that the inequality was exacerbated by the lockdown. Here's some of our COVID statistics. I'm going to go into the epidemiology now. So as of yesterday, this data comes from yesterday, we had 5.3 million tests conducted, positive cases about 770,000, recoveries 710,000, and 20,000 deaths. So from March 5th until today, the overall positivity of our test is 15%. The case fatality rate is about 2.7%, and the recovery rate is 92%. Of course, we know, those of us who are epidemiologists here, know that there's a lot behind these numbers, and I'll go into some of them now. So the impact on the COVID epidemic, first, I thought this was interesting data to look at the relative daily increase in the number of cases. So before lockdown, there were about 41 it increased in number of cases per day, and then it went down to 5, then to 6 to 4, and now it's down to 0.24. So right now we're about 2,900 cases per day, down from a peak of about 14,000 in July. So you can see this is where our peak was in July, and now we're down here. Right now, the government is conducting about 20,000 daily tests, and there's about 80 deaths per day, and the mortality rate is less than 3%. COVID testing has been a source of a lot of debate here. I know I work in the health facilities here, and I've seen that the policies have changed every couple of months because of lack of testing or lack of availability of testing. And so at the beginning, there was a really long wait for tests that people were waiting 1 or 2 or 3 weeks, which kind of makes getting the results of the COVID test futile at that point. So we were really just telling people to go home and wait for 2 weeks and to quarantine. Now you can see that the national positivity is about 10% as of last week. So we had 2,132 tests out of the 21,000 tested, but the testing strategy varies by province and is still targeted to those most at risk. So really we're testing mostly symptomatic patients, patients with comorbidities, or healthcare workers. And so you can see here how South Africa is comparing to the rest of Africa in terms of the positivity, the daily new confirmed cases due to COVID-19. So on the y-axis is your daily tests, and the x-axis is your new confirmed cases. And you can see the United States way off in the stratosphere. The case fatality rate is also on the rise, unfortunately. And you can see here in South Africa that the case fatality rate went down in July and then is coming back up past 2.5%. And so you can see that it's varied quite a bit, but right now it's at its highest. Colleagues of mine have also done analysis on excess deaths and reported COVID-19 deaths. And so what they've looked at here is the number of excess deaths exceeded 17,000 from natural causes between May and July. And they're attributing that 59% higher than normally would be expected. So more data are needed, of course, on the underlying causes of death, but these excess deaths demonstrate that a significant proportion of the current excess mortality being observed in South Africa is likely to be attributed to COVID-19. So when you go back to the numbers where I presented here about the 20,903 deaths, those are the confirmed cases, but we really think that it's significantly higher than that, probably even double. There's been a lot of conspiracy about why we have lower mortality rates in Africa. And here there's several different hypotheses that were presented in the press and also in the medical journals. We do have a younger population. So 62% of Africa, sub-Saharan Africa, is less than 25 years old, and 3% are 65 years and older. There's also lessons learned from previous outbreaks. I'm really looking forward to hearing more about DRC because there's a lot of comparison here with Ebola and other outbreaks that we've gotten used to responding to quickly, and that maybe that was the reason. There's also a time to prepare because of the lag in the first receipt of the first cases. So we knew it was coming. We knew COVID was coming because of what we saw happen in Europe, in Asia, and the United States. And our first cases were in March. There's trials ongoing to assess whether the BCG vaccine, which is a vaccine that is against tuberculosis, and there are some trials ongoing. And there's resistance due to exposure to other coronaviruses, another hypothesis that is going around. So biweekly cases of COVID-19 in South Africa, you can see here that we're in the pink compared to the rest of the world that's in the dark purple, which means that there are about 100 to 500 cases per million people. And the cases have gone down significantly, but they're starting to rise a bit in the past couple of weeks. So the next big question is, when is the second wave coming? And this is data from Western Cape, where I live in Cape Town. And you can see here that the government is tracking this closely and has done this calculation of an index that quantifies the deviation of the data of the hypothesis from a single wave. And so what they're calculating here is that how much the risk is that the next, that this province or this district is going to have a second wave. And you can see here in pink, has been all over the news, is the Garden Route. And the Garden Route wasn't hit very hard in the beginning, and now they've gone past the high risk. And so the risk of them going into a second wave is significant. And we're also seeing an increase where we are in the medium risk in the other city of Cape Town, for example, in green, is headed towards the medium, along with the other areas of the province. So this is a colleague of mine who did this work from the Western Cape Department of Health. And there's a differential burden of COVID mortality within Cape Town. This highlights again the inequity in South Africa. So the black dots here are where you have 150 people that are greater than 60 years old. So these are really your older populations in the different districts. And this is an overlay of the same map of Cape Town, but with your socioeconomic index, with your needy, very needy in red, and your average need. And you can see that there's a lot of overlap here. And in the Kailicha and Klipfontein, you can see that the standardized death rates are significantly higher in those areas that have both the socioeconomic index need combined with the older population. And so Kailicha and Klipfontein were hit the hardest within the initial mortality estimates. Again, my colleague did this analysis. I won't go into too much detail, but she evaluated the adjusted hazard ratio for dying from COVID-19 in 3.5 million patients that were active public sector patients, and found that men, older people, people with diabetes, any kind of diabetes, any other non-communicable diseases like hypertension, kidney disease, tuberculosis, and HIV were all risk factors of death. They're not risk factors for getting COVID, but they're risk factors of dying for COVID after adjusting for location and subdistrict. So when they calculated the standardized mortality ratio, they looked at the actual number of COVID deaths in people living with HIV versus the expected number of COVID deaths in people living with HIV if their age and sex-specific COVID-19 risk of death was the same as people without HIV. And they found that the standardized mortality ratio for the increase of COVID-19 death in people with versus without HIV in Western Cape was almost 2.4. So that means that people living with HIV had a 2.4 times risk of dying due to COVID-19. And this across the public and private sector, about 8% of COVID-19 deaths were due to HIV. And then she did another analysis on viremia and immunosuppression to show that people that were relatively well, so their viral load was low, lower than 1,000 copies, still had an adjusted hazard ratio of about 3. So you can see here of dying. Probably well, same also at high risk of death, unknown. They're all high risk of mortality regardless of the viral load at baseline, adjusted for other variables. So take-home message in her analysis is there's a modest 2 times risk of COVID-19 associated with HIV and TB, but it may be overestimated if there's confounding, of course. Those with HIV or younger, where overall risk of COVID death is low, and less than 10% of COVID deaths in our population, however, are due to HIV and TB. So most of the risk of the COVID deaths, again, when we go back here, is really due to the other NCDs. So the diabetes, hypertension, chronic kidney disease. And so the government in the public sector, they changed their policies. And so that when somebody was diagnosed with COVID and was diabetic, they were put immediately into the hospital to get treatment. And I think that has impacted on the survival of specific populations with previously diagnosed NCDs. So living under lockdown, this is an app right now that's the power is in your hands, that's being advertised, the COVID alert app. And when I go to, sometimes when I go out, I get an alert that I was in an area with somebody else that's been diagnosed, and it lets you know when that happens. For those of you who know me, my research is in HIV prevention, like Annie presented, in pregnant women. We had to shut down all of our research in March and April and restarted in May as an essential service by the government. Our study retention declined by over 1/3, and these are pregnant women that are coming in for antenatal care. Mostly women don't want to come in. We interviewed them, they don't want to come into the clinic for care, or they moved out to rural areas. And this has impacted on all of the pregnancy and birth outcomes. We're seeing a lot more stillbirths or low birth weight infants or miscarriages because of that, because of the access to care, but also because of COVID, perhaps. We don't really know. And so I felt helpless at some point, and I decided as an epidemiologist to volunteer with the Department of Health to do contact tracing and learn more about how people were contracting, spreading, and about health outcomes and inequalities during lockdown. And I learned a lot about super spreader events. They were isolated to factories, supermarkets, and funerals. Now we've developed apps. So the government has developed apps to help with contact tracing, but volunteers are still used. And I was just contacted again by my volunteer group to start again. So we're back on the upward slope of the epidemic, unfortunately. And with contact tracing, you realize what's going on. And right now, a lot of the epidemic is being drawn by people going out and going to either funerals or going to parties and going to end of the year festivities. And so our hypothesis is that in the next month or so, we're going to see the next wave, especially around the holidays here. That is it. I want to thank you for listening and thank you for your time. I'll hand it over to any kind of questions or discussion. Thank you.
Dvora, what a fantastic presentation, and it's so interesting to see and hear what's going on over there. I'd love to open up the floor to questions. If somebody has a question, they want to either oh, somebody's in the waiting room here. Does anybody have any questions?
Yeah, may I ask a question, please?
Yes, please.
Hi, I'm Derek Pham, an anthropologist. I've lived in Cape Town for about a year in the past. I had a question for you about the domestic labor situation. What is going on with domestic workers? Have they been staying home? Have they been staying at in the old domestic labor quarters of the White Houses where most of them are working, or how's the situation unfolded?
Yeah, thank you, Derek, for the question. Domestic workers had to stay home for the first 2 stages. So I don't know if you were there, but the stage 5 and 4.
I was there a couple of years ago, not recently, sorry.
Level 4 and 5, domestic workers were not able to come to work. And so that left a lot of people without incomes if they were getting paid daily or weekly, and that affected a lot of people's food security. And so the government stepped in, and the NGOs, a lot of the NGOs stepped in to give people food and support with rent and other social services. Domestic workers now can come back to work. And so as of a couple of months ago, they can, and it's really up to the employees to screen them. But there has been a lot of the transmission, as you know, is household transmission. So that's been a bridge from a lot of the communities is through the domestic workers.
Other questions?
Yeah, very nice presentation, Dvora, very well put together. Obviously, the United States has a lot to learn from South Africa. And of course, the difference is the level of compliance of the population. South Africa appears to have had a very high level of compliance with the lockdowns and distancing and so forth. To what do you attribute that? Gesundheit.
Thank you, Roger, for the feedback and the Gesundheit. A lot of it was the police. People were scared. I think that people were definitely scared that the police was going to come and get them. That's what I was going to show on the BBC videos. There was a lot of fear. The police were pretty brutal during the lockdown, and it was well enforced. There was a day down on the beach where some people went down for a walk and they were arrested. And so that kind of communication got out into the community, and people were scared of the police. Part of that, and I think it was also part of the government leadership, having the president get up there and put on his mask and say, stay home and explain why people need to stay home, why they need a social distance, and the risk of death to the most vulnerable. And so I think it was a combination of fear and combination of understanding and empathy for others. I can't say that it was respected for all. I did say that, you know, in a lot of the rural areas and in the townships, it wasn't as well enforced in terms of lockdown, but it was also, these are people living in one-room shacks. And so it's really impossible to stay in a one-room place with your family for weeks on end. And so people did move around, and the police would come in and enforce things, especially at night. And there's been a curfew since the beginning of March. There's been a curfew. So the curfew was at first you couldn't leave your house, and then it was 8 p.m., 10 p.m., and now it's midnight. And I think they're going to change our curfew again to be 10 o'clock soon. And after the curfew, there is police on the street, and people are scared. The Uber drivers won't drive you around. So if you're stuck in a restaurant or something and need to get an Uber home or get something home, there's nothing out there. So it's very well enforced, at least from my experience living in the city.
Very, very interesting. I mean, I think of China and South Africa appeared to have had a very similar approach. I find it interesting because China clearly is not a democracy, and South Africa ostensibly is a democracy. So it's interesting that the lockdown works in both sides of government, although police enforcement, excessive police enforcement is a toughie.
It's really a hard balance. Yeah, I think the excessive police enforcement was terrible, and it was all around the time that the Black Lives Matter was happening and the police brutality was happening in the US. And so it was really a difficult time because you could see the same thing happening here in South Africa during COVID, and the government was using, and the police, they were using COVID as an excuse, really to go and to brutalize some communities. So it's a fine balance, and I think it's sometimes it was taken a bit too strongly against some communities. Paula has a question to share more information about the intersection of pregnancy, HIV, and COVID. So that's really my research area, is that intersection, and now with COVID. And what we're seeing is that because of the lack of access to healthcare for so long, is that women did not have access to family planning or to contraception. They didn't have access to PrEP or to condoms or to HIV testing because of the lockdown. And at least where I'm working is we're seeing a lot more incident HIV infections, unfortunately, in pregnancy and unwanted pregnancy. So I'm writing up a paper right now about that in the community where I'm working, about this flux of increased unwanted pregnancy, incident HIV due to COVID lockdown. And there's a lot of jokes around it, like these are all COVID babies, but when you speak to the women, it's pretty devastating. They missed their Depo-Provera shots because they were in lockdown. They acquired HIV because they were sexually active, and now with COVID, they're scared of coming to the clinic. And so all of that is it's a perfect storm, especially in an epidemic where we have the highest HIV rates in the world. For the slide where South Africa had a much higher number of infections compared to the other 9, is that due to more testing in South Africa or higher connectivity, or other reasons? Definitely more testing. I could show you another slide where it shows that South Africa has done far more testing than our neighboring countries. And the mobility, but the connectivity, as you're saying, our mobility really went down between April and July. There was very limited connectivity in Cape Town and Johannesburg. Oh, I see what you're saying, because of the connectivity to Europe. There was a lot of international infection, definitely, that brought the rates up high, especially in Cape Town. And but I do think that some of it was increased, just the availability of testing. And other countries that probably had European migration also would have seen similar rates had they had enough testing going on. Would have been some unintended questions of strict lockdowns on mental health. And so I think I presented a little bit about this, is about the increased rates of gender-based violence and abuse and hunger, suicides as well, homicides have gone up. A lot of the indirect impact on the mental health has been really severe. And I do have colleagues that are evaluating that right now and still looking at it. Please comment on labor. Can you please comment on labor migrant specific risks and experiences? That is a big one from Victor. Victor, labor migrant specific. So if you know anything about South Africa, you know there's a lot of xenophobia, and to access healthcare and access even sometimes COVID testing, you have to be South African. And so the problem is a lot of times that the migrants and people that come from other countries may not have access to healthcare like South Africans do. And they certainly don't have access to the social grants and the social services that the South Africans do. So you need a South African ID to take advantage of that. And so there's been a lot of homelessness. If you follow that, there's a big DRC community, a Congolese community that's homeless, and they've been fighting for to become refugees now. And a lot of this has gotten exacerbated and worsened because of COVID, unfortunately. And a lot of the xenophobia has gotten worse because of this. Next question. will the Biden administration communicate with South African health agencies and employ lessons South Africa and the US to, I hope, in attempts to curb COVID in the United States. I think that the Biden administration will be far more open than the Trump administration to communicate with South Africa health agencies and learn from South Africa. I do think that in a lot of ways, Americans still think that they know it all and that don't want to come to Africa and to learn from here. But I do think there's a lot to learn from a South African context. So I do hope that they will come and talk to their South African colleagues in the coming months to learn more about what we've done here. We had signed up for a trip to Botswana in June 2021 via Johannesburg. Now talking about 2022. Any observations on international travel possibilities moving forward? I think that travel for right now is open. You'll want to get tested before you come here, and you just have to wait. I think once you have access to vaccines, we've talked about on the radio today, they talked about having access to vaccines in the middle of next year. And so, but if you have access to vaccines in the United States, you'll be the first to get those. And then once you're vaccinated, I think you should be better off in terms of international travel. And there was an article, I think on the BBC today, that I talked about requiring vaccines for international travel in the coming few months, once vaccines become available. Is South Africa doing contact tracing? If so, how are they doing it? Thanks, Paula. I was doing contact tracing, so I got to learn a lot about the government contact tracing during lockdown. And I was a volunteer. And we were doing it all through Microsoft Teams or Google spreadsheets. And we had a training, online training, and they gave us phone credits to make phone calls in our community. So it was mostly volunteer led with the government. Right now it's become more official. So this is in the beginning, in the first few months, it was very much government and volunteer led. And now there are more private sector groups and apps that have been created to help with contact tracing. But inevitably, a lot of the work has fallen to the government and to volunteers. And so like I was saying at the end, I've been called back to start contact tracing again. And so a lot of it is just volunteer groups that are doing contact tracing. And inevitably, you can't reach everyone. So we would prioritize people that needed the most help, and how we would prioritize with them was really looking at their comorbidities, their age, and the time since their diagnosis. So if they had already gone 2 weeks since their diagnosis, you knew it was too late. Similar to what they said happened in the White House Rose Garden. But so really it's just prioritizing time since diagnosis. What preparations are being made for vaccine acquisition and distribution? Thank you, Tom. There is a group of scientists and people working on that right now, and that's why I was listening to the radio this morning, learning more about that. And they are working with Pfizer and Moderna. We're also testing the AstraZeneca vaccine, which has also been shown to have a 70% efficacy in recent, I think that was released today. And so we're looking at all different, I think the South African governments are looking at all different options and working with their donors to get the funding together for the acquisition and distribution. And the distribution will be primarily to high-risk populations. So again, healthcare workers, older populations, and people with comorbidities like diabetes. There's definitely, Claire asked the question, is there concern about the availability of vaccines, i.e. COVAX and vaccine nationalism? That's a really good point. There definitely is concern about the availability of vaccines. We haven't bought into vaccines like the rest of Europe and the United States. South Africa hasn't bought in. So the fear is that we won't get prioritized. And that's what they were saying. We probably won't get vaccines here until middle or end of next year, if we're lucky. And then again, it will be prioritized to those populations highest at risk. What is the state of research on the BCG as a contributor to low rates in South Africa? Derek, that's a great question. I was researching that today, and it seems like it's really up in the air. There's been some research to show that it's been effective at reducing morbidity and mortality, but then they really need clinical trials and randomized control trials. So a lot of them have been observational. And so there are several different studies ongoing, both in South Africa and in Europe, to show that the role of the BCG vaccine. So it's still a hypothesis that's being tested, I would say. Tom, can you comment on the quality of care for COVID, especially in government public hospitals? The quality of care, remember, I'm in Cape Town, and Cape Town is it's another part of South Africa that's different than the rest of the country. But from what I saw here, working in the clinics, working with my colleagues here, the quality of care was really excellent. They opened up in the ICC, the International Conference Center here, which is a huge conference facility. They opened up a hospital and they rarely had to use it. They actually closed it down. So the capacity here in the big hospital is pretty good. And from what I can see is that the quality of care by the nurses and doctors, and they've recently just changed the guidelines to include remdesivir and to include all of the different technology that we know are the drugs that we know are effective in the United States and in Europe to become available in the public government hospitals. It has been some publications and some recent media about other poor government hospitals in the Eastern Cape where the COVID epidemic is getting worse. And so that is a problem, is that there's a huge even disparity or a huge difference in some of the government hospitals. And so there are some poorer hospitals that didn't have any ventilators and didn't have access to drugs. And also they only have one doctor per 1,000 people. So the ratio of doctors to patients was very high. And so that's still a big problem in the more rural, poor areas in South Africa. The Ministerial COVID Advisory Group, this is Tom's question, is it still active and what role are they playing? The COVID Advisory Group is still active and they are still advising the Department of Health and the President in all of their COVID policies and the decision to go up and down in terms of the risk assessment from level 1 to level 2, et cetera. So I think that the advisory group has been quite helpful in making these decisions. There was some politicking in the beginning where they wanted to different policies in place, but I think that's always going to happen. Do we take one last question, Annie?
Yes, let's see. Anybody else have a question here?
It's the last one here. Is most of the COVID policy making primarily being directed by the national government? What role have the municipal government played in directing policies from SAFIA? That's a really good question. So most of the lockdown and all of the other policies have been national. The municipal governments, and that's a big difference with the United States, obviously, is that all of our policies have been national. The municipal governments have made decisions about purchasing of PPEs and allocation of resources. And so they've made decisions about how to allocate money and allocate money for sourcing of PPEs and ventilators and making sure that the hospitals were up to being prepared and that the healthcare resources were available. But otherwise, all of the policies was from the national government. Great questions.
These are great questions. I just actually have one last question for you, Dvora, and that is what if you were in charge of COVID response in South Africa, what would you be doing that isn't already being done?
It's a good question. I would do a couple. I'm strict. We saw a big outbreak here in a nightclub. So it's the end of our school year here. Our school year goes from December to December. And so the seniors, we call them the seniors in high school, were going out because it was their end of the year. And I think they had like 85 cases from a niclub. I sure as hell would not let my kid go to a nightclub, first of all. And I wouldn't open nightclubs, and I would, have stricter guidelines on nightclubs and bars and that sort of thing. I don't think that that's really an appropriate thing to have people dancing and sharing shots and that sort of thing. But also, I would really invest heavily in contact tracing. I think without contact tracing and ability to find people and let them know quickly that they're infected and what they need to do, you're not able to get a handle on the disease. And right now what we're seeing is that there's not enough research technology so much.
Well, that is fantastic. A great response. All right.
Thank you,
Well,
Annie.
this was really fantastic. Thank you so much, Dvora. I've learned so much during this time. I have so many more questions. Obviously, I'm always looking forward to hearing from you and talking to you. But I think we've all learned quite a bit and look forward to hearing more. It'll be really interesting to get another update date from you in a couple months as things continue. But thank you so much for your time, and I know it's late there. So on behalf of all of us, thank you.
Thank you, Annie. Thank you, everyone. I really appreciate the feedback. Take care. Stay safe.
Thanks to everybody. And to everybody else, we'll be having more of these and we'll be letting you know as time goes on. And if you have suggestions for international talks that you would like to hear, please do send it our way. We'll do our best to find opportunities and ways to accommodate.